Hello everyone, this review done by Siqueira and his group in 2022 in Journal of Endodontics. The aim of this narrative review is to update and expand the discussion about the endodontic application of this invaginatus as well as the treatment recommendation based on anatomic consideration and neo technologies. It is a developmental malformation that radiographically look like one tooth inside another one, and its prevalence in permanent teeth it varies from less than 1% to 10% depending on the population. And the genetic factor related to the ethnicity may be the reason for the difference in the prevalence. And 43% of the cases representing a bilateral occurrence. And the most affected tooth is the maxillary lateral incisor, followed by maxillary central incisor, canines, and premolars. And the occurrence in the molar is very rare, and the primary teeth also exhibit this anomaly. Olar classification in 1957 is the most widely used classification, and it include three types based on the vertical extension of invagination. And the figure 1, image A, it is the type 1, which consists of invaginations that is limited to tooth crown and does not penetrate the root. In the figure B, it is the type 2, which is invagination extend through the root and end in the blind sac without communication with the periodontium. In the figure C, it is the type 3, that the invaginations go all the way from the crown opening to the periodontal ligament and have two subtypes. The type A, it's opening laterally, and type B opening apically. And the coronal type of this invaginatus is by far the most commonly variety seen. This invaginatus is commonly diagnosed as an incidental radiographic finding unless the patient presents with pain or swelling. Radiographic examination is essential to a correct diagnosis of this invaginatus. The invagination usually appears as a radiolucent pocket lined by radio-opaque enamel border. CBCT has a great value to diagnostically differentiate between this invaginatus and palatal radicular groove. The management varies according to the invagination extent, pulp and pre-radicular status, and the stage of the root development. The new technologies such as guided endodontics and computer-aided dynamic navigations and magnification by operating microscope and dye can be used for planning and more accurate management of this invaginatus. The recommended management of teeth with this invaginatus can see in this figure. In the normal bulb, for both mature or immature root, there is no treatment. In the irreversible bulbitis with mature root, needs single visit root canal treatment, and immature root, vital bulb therapy required. And in necrotic bulb, for mature root, antimicrobial root canal treatment required with supplemented disinfection by intracanal medicament with calcium hydroxide. And for immature root, apexifications or regenerative endodontic procedure required. Regarding to the invagination, in the type 1 with the normal bulb need to seal or fill after small preparation, and in the irreversible bulbitis or necrotic bulb need to seal and fill or include the invagination in the final access cavity. In the type 2 with the normal bulb and irreversible bulbitis need to seal or fill after small preparation, and in necrotic bulb they need to treat the invagination as a root canal, and sometimes it's having perforating to the apical root canal, and sometimes join to the root canal during preparation. In the type 3 with the normal bulb and irreversible bulbitis, if there is no apical periodontitis, need only to seal or fill after small preparation, and if you have apical periodontitis, treat like a root canal, then supplemented with the disinfection, which means intracanal medicament. And if you have necrotic bulb, treat it as a root canal with supplementary disinfection, which means the intracanal medicament. So, in my opinion, We need a classification based on 3D imaging to have a better planning and a more accurate management of these type of cases. So therefore it is important to understand the different manifestation and condition that the clinician may face when dealing with this anomaly to apply therapeutic strategies that are more predictable to successfully treat and save the teeth with this invaginatus. And thank you.